Okay, so we are starting now. We are welcoming you to 191st edition of Thursday Musings. Today we'll be talking about role of ketamine in treatment-resistant depression and suicidal ideation. Next slide, please. My pleasure to introduce Professor Dr. Tufan Pati sir. He's probably in travel and might be joining us late. So welcome, sir, in your absence. Next slide, please. Dr. Amrit Bhat Joshi is also in travel, my colleague. Next slide, please. I am the moderator of today, Dr. Alim Siddiqui from Lucknow. Next slide. Dr. Vishal Chhabra is the new force behind the scenes. He is arranging many things for us, helping the team in many ways. Welcome, Dr. Vishal. Next slide. My honor and pleasure to introduce our chairperson for today, Dr. Rajiv Mehta. He is MBBS from UCMS, New Delhi. He is MD in Psychiatry from Maulana Azad Medical College and GB Pant College, New Delhi. He is MSc in Disaster Mitigation from Sikkim Manipal University of Health, Medical and Technological Sciences, Sikkim, with distinction. Got excellent for his work both as senior resident and junior resident. Has publications in national, international journals, printed scientific papers in national, international conferences, has undertaken various research works, authored 2 books, Psychiatry, The Ready Reckoner, doctor's publication, Speak to Anyone Easily. Welcome, Dr. Rajiv. Next slide, please. Our own Dr. I.R. Rajkumar, welcome, sir. He is MD and DPM. Did his UG from JN Medical College, Belgaum, PG training from Seth GS Medical College and KM Hospital, Mumbai. He has been awarded with JC Marfatia Gold Medal in Psychological Medicine at the ND examination 1982 by Bombay University. He is in private practice from Baroda since 1983. Both the chairpersons have been prolific in doing ketamine therapy. So we are looking for their vast experience today. Next slide, please. I'm handing over the session to the chairpersons to introduce the speaker and introduce the topic. One of you can introduce speaker, the other can introduce the topic. Thank you. Over to you, chairpersons. Please unmute and speak.
Right. Dr. Rajkumar sir, can I introduce the...
Sure. Go ahead.
Right. Thank you. So it's a new therapy, ketamine in treatment-resistant depression and suicidal cognition. Our speaker will be Dr. Rajrishi Guha Thakurta, who has done his MD in psychiatry and DPM. He is currently working as assistant professor of psychiatry in Midnapur Medical College, West Bengal. He is an honorary treasurer of Indian Psychiatric Society West Bengal chapter since 2022 and honorary secretary of IPS KLBB chapter. And he was an organizing secretary of PsyCon 2020 and ex-convener of IPS, Artificial Intelligence and Machine Learning Task Force for the year 2023 and 24. And he has many publications, around 26 publications to his credit. So I welcome Dr. Thakurta for the speech, today's speech. And over to Dr. Rajkumar to introduce the topic.
Good evening, friends. It's a pleasure to join you all on this evening to know something about ketamine therapy. Yes, over the period of time, we faced a lot of issues as far as depression is concerned, suicide is concerned, needed something immediate relief that could sort of at least elevate the sufferings of human beings. Treatment-resistant depression was one area where perhaps we were hitting against the wall and unable to find any way out. In the last, say, 5 to 7 years, ketamine has gradually made an entry. However, in India, at least in the last, say, 3-4 years, many of our colleagues have started using in various routes. Some used as nasal sprays, some used in oral, some used in subcutaneous, and recently people have started using the ketamine infusion also. So in cases of depression and people who have suicidal ideations or high risk suicidality, perhaps this has come up as a boon. So too the working depressives who wish to get better as quick as possible, even on day one, and continue with their work. Perhaps ketamine has helped us. It's also used in pregnancies having depression. So that is another area perhaps where we can look into. Uh, we have a genuine person who has worked on ketamine administrations to help us go through and know more about it. May I welcome Dr. Rajrishi to kindly take over the platform.
Thank you, sir. Am I audible?
Yeah.
A very good evening to the respected chairperson of the series, Dr. Tufan Pati, Dr. Amrit Parjoshi, Dr. Alim Siddiq, the moderators, Dr. Rajiv Mehta and Dr. I. Rajkumar, for giving me this platform to speak something about ketamine in treatment-resistant depression. Before sharing the slides, I would like to say a couple of words. That is, is it visible?
Yeah, it is visible.
Okay. So, while my senior residency in Burdwan Medical College, we had an idea about treatment-resistant depression. So, one of our anesthetist colleague who was very much interested, he was also a DPM, and he was then the associate professor. And my HOD at that time was Professor Om Prakash Singh and Professor A.K. Bhattacharya and Professor Ashim Malik, all of whom are well known in the IPS cabinet members. So we started the three residents, we started infusion ketamine in treatment-resistant depression. So at that time, we started with preliminary assessment, and then we gave the infusion with the anesthetic setup. We had the ECT setup, so we had the modified ECT setup, and there we used to give the infusion setup. The patients were selected, they were kept drug naive for 5 to 7 weeks, or sometimes 2 weeks to 3 weeks, stopped all medications, full medical checkup, and then we started 1 or 2. So what happened was that we were getting good results, which I will be sharing through my presentation. And then some cases of suicidal ideation also came in, and at that time few literature were available in Indian context. We had to borrow many literatures, and some of we had to purchase from Professor Zarate CR. He is one of the pioneers in ketamine therapy. So we published a case series on treatment-resistant depression. We then published an original article on treatment-resistant depression and role of ketamine infusion. Then we moved on to your suicidality, assessing suicidal risks, and then there were a few case reports we published, and then we made original article which was published in Indian Journal of Psychological Medicine. So at that time we did not have the access, we opted for IJP, but it was not accepted, so we again reverted back to Indian Journal of Psychological Medicine. And then that was quoted by many. And then a series of things happened. As I grew up and entered into government service and currently posted at Mednapur, but my clinic setup is at Kolkata. So I had to travel a lot. But anyway, we got the license for purchasing or procuring the ketamine injections, and we had an intensivist who is one of my colleagues also. He is practicing at Apollo Hospitals, so he lives nearby. He is in charge of that clinic right now. So let me come to the presentation briefly. We will have the introduction. We will have the Schedule X drugs according to the Schedule X drugs according to the Drugs and Cosmetics Act in India. Ketamine, the formulations, dosage, approvals, contraindications, adverse events. What are the proposed uses? What is the mechanism of action of ketamine? What are the clinical evidences? And the most important thing, how to use in OPD and IPD. And at last, a summary. So ketamine is a racemic mixture comprised of the R enantiomer of ketamine, which is called the R-ketamine, and the S enantiomer called S-ketamine or asketamine. ASK also is being used. So it is a Schedule X drug. Ketamine injection is well known to all the participants here. It has been approved as an anesthetic agent by the DGCI in 1971. It has been approved for general anesthesia either alone or in combination with other medications, usually used in short-term medical procedures which do not require the skeletal muscle relaxation. Induction agent for general anesthesia. It is basically a non-barbiturate dissociative anesthetic. Non-competitive NMDA and glutamate receptor antagonist, which we will be talking about the entire scenario. It blocks the HCN1 receptors. The NMDA receptor has a significant role in the etiology of depression. Ketamine, through its NMDA antagonistic action, works rapidly in controlling symptoms of depression and acute suicidal ideation. I have given the basic reference here from which I have accessed this. In brain, ketamine modulates the glutaminergic transmission by acting as an NMDA receptor antagonist. The NMDA receptor binding affinity of S-ketamine is 3 to 4 times higher than that of R-ketamine. Compared to the racemic ketamine and R-ketamine, S-ketamine is believed to have fewer side effects. Intranasal S-ketamine was approved by US FDA. The brand name is Spravato by Janssen, available in 56 mg and 84 mg intranasal spray in March 2019, but it was not approved by the DCGI. S-ketamine, a Schedule 3 controlled substance, may be subject to abuse and diversion. So, what are the approved formulations for ketamine by the DCGI? Now, one is amitriptyline hydrochloride plus ketamine per gram cream. It is for the treatment of patients suffering from neuralgia, and ketamine hydrochloride by Themis, anesthetic agent, since 1971. So available formulations which are available in India are injection 100 mg and 50 mg. Ketamine hydrochloride, if we see, Messrs. This was taken from the site in the year 2023, 13/6/2003, that is about a year back. Messrs. Themis, they sought the recommendation, and the firm presented the modified protocol for the phase 3 clinical trial with relevant publication for proposed indication before the committee. I like to mention that my article was reported here, also put on this before the DCGI. After detailed deliberation, the committee recommended for grant of permission to conduct the phase 3 clinical trial as per protocol presented by the firm. So ketamine hydrochloride by Messrs. Themis Medicare, injection 50 mg per ml, is the proposal A, that is phase 3 randomized double-blind placebo-controlled parallel group comparative multi-center clinical study to evaluate the efficacy and safety of ketamine subcutaneous injection in patients with TRD and major depressive disorder and the acute depressive episode before the committee. After detailed deliberation, committee recommended that the firm should submit the revised phase 3 CT protocol design and so on. So approval of ketamine and its isomer by FDA. IV ketamine, that is the racemic mixture of R-enantiomer and the K-isketamine, is approved as a general anesthetic as the sole anesthetic agent for diagnostic and surgical procedures that do not require skeletal muscle relaxation, for induction of anesthesia prior to administration of other general anesthetic agents, as a supplement to other anesthetic agents also. Intranasal ketamine, as we were talking about, has been approved by the US FDA in the year 2019 for treatment-resistant depression in adults, depressive symptoms in adults with major depressive disorder with acute suicidal ideation or behavior. But the thing is, intranasal ketamine or ketamine in general has its approval only for unipolar depression in major depressive disorder and acute suicidal ideation associated with depression. Dosage and administration as an anesthetic, there is no use in this slide, but just an introduction that the anesthetist used about 1 to 4.5 mg per kg administered slowly. For the intramuscular route, they use 6.5 to 13 mg. Maintenance of anesthesia, increments of 1/2 to the full induction dose may be repeated as needed. So it can be supplemented with other anesthetic agents. The regimen of a reduced dose of ketamine supplemented with diazepam can be used to produce balanced anesthesia by combination with other agents. Now, mechanism of action. The specific mechanism of action in depression has not been fully elicited. Although it is postulated that S-ketamine, like ketamine, is a non-selective, non-competitive antagonist that blocks the NMDA receptor and ionotropic glutamate receptor on GABA interneurons, and activate the alpha amino 3, that is the AMPA receptor, thereby increasing neurotrophic signaling that restores the synaptic function. The inhibitory share the last dosage slide once more. So do I have to share the previous slide once more?
Sir, you proceed. We can go it again in the question session.
Okay, thank you, sir. The antidepressant properties of S-ketamine are not mediated by known mood modulating pathways, such as the monoamine or the GABA pathways or the opioid axis. The action of S-ketamine on AMPA receptors may ultimately improve neural plasticity and synaptogenesis through signaling pathways, resulting in enhanced brain-derived.
Incoming call from an active unidentified by Truecaller.
The rapid effects of S-ketamine evident within about 1 week of initiation, and then we can see that the action of S-ketamine on AMPA receptors ultimately improves the neural plasticity, synaptogenesis through signaling pathways, resulting in enhanced brain-derived neurotrophic factor production, which is decreased in the prefrontal cortex and hippocampus in patients with stress and depression. Now, what is the mechanism of action of ketamine? So, presynaptic and postsynaptic NMDA receptor blockage causes a glutamate surge, increase in glutamate. So, what are the some problem? Stop sharing or what? So the key targets are NMDA, which is a strong antagonist, antidepressant, and the pro-cognitive effects. Acute dissociative effects also do happen. At the AMPA receptor, it is an indirect agonist through increase in glutamate release, causing the antidepressant effects. At the D-serine site, which was shown in the previous slide, if you can just have this site in mind, the D-serine, this is the site, this is being blocked, and this is the site for phencyclidine, PCP, that causes hallucinations. This is also blocked. So there is an increase in glutamate. This we can explain through the side effects what we commonly face while using ketamine. In glutamate, there is an increased release causing the antidepressant effects. The mu opioid receptor, it is a weak agonist, antidepressant and analgesic effect and potentiate acute euphoric effect. At the mu opioid 2 receptor, it is an antagonist. Kappa receptor agonist, delta receptor agonist. Serotonin transporter weak inhibitor, but what we have to see is that the dopamine 2 receptor, it is an agonist causing the acute psychomimetic effects. Serotonin 5-HT3 receptor, it is a weak antagonist causing also the antidepressant effect. So what we are talking about is that it blocks the presynaptic NMDA receptors in the GABAergic neurons, there is the interneurons here, so causing a disinhibition of glutaminergic discharge. So now the interneurons are stopped, so there is increase in glutaminergic transportation. Then there is a surge of glutamate release. The postsynaptic AMPA receptor, increase in sodium and calcium influx. Here the sodium and calcium influx are coming. Release of BDNF, number 5. This is from Stephen Stahl. Increase in the TRKB receptors. Increase in the plus, that is the mTOR receptors. The mTOR receptors we could not, this one is this 7th point. This is very important for the suicidal part of you when we will be talking about, because it is the mammalian target of rapamycin. This mTOR receptor actually causes this synaptic plasticity and there is increase in the dendritic spines. Coming to other effects, the channel effects are that there is decreased NMDA, it blocks the HCN1 which I was talking in the first slide, it blocks the acetylcholine channel, it blocks the L-type calcium channel, there is increase in glutamate, noradrenaline, dopamine, cortical acetylcholinesterase, pontine acetylcholinesterase, opioids, mGlur, MOX, so on and so forth. So there is a chance of gene expression, immediate early genes, GFNAP expression, increase in BDNF, increase in mTOR. This is very important for synaptic homeostasis and apoptosis. So first comes the hypnosis effect, then comes the psychomimetic effects, then comes the analgesic effects, and in further lower doses comes the antidepressant effects. So to reverse it back, at lower doses antidepressant effect, then analgesic effect, then higher dose psychomimetic effect, then the hypnotic effect. Now, some clinical studies have found that the antidepressant and anti-suicidal effects of ketamine were blocked by opioid antagonist naltrexone. So this was a major confusion with various studies while we were conducting the case series reports or application in our clinical practice. But however, we later found out that ketamine does not act as a mu opioid agonist, but functional mu receptors are permissive for the antidepressant effects of ketamine. So even if naltrexone is given, there are some receptors, that is the mu receptors, mu opioid receptors, that are permissive for the antidepressant effect of ketamine. Cholinesterase inhibitor causes the procognitive effects, which is a potential clinical effect. And it is antagonist at the alpha-7 nicotinic receptor, muscarinic receptors, increase in blood pressure and heart rate. Very important. Muscarinic receptors and antagonism increases the blood pressure, heart rate. At the sigma-1, it is an agonist, causing antidepressant and some cardiac side effect. At the sigma-2, it is agonist, causing the antidepressant cardiac side effect. What I was talking about is the mammalian target of rapamycin, mTOR. There is downstream activation by the glutamate system causing the antidepressant effect, and mTOR has the second channel called mTOR C1, where there is activation causing the neuroplasticity effects. So GABA A receptor also agonist. So in some studies we have already found that there is not only a decrease in the depression scales or depressive symptoms, but there is amelioration of the anxiety symptoms as well, and that is being studied in recent studies that has been published in Indian Journal of Psychiatry also. So, what is the basic story? S-ketamine blocks NMDA receptors. There is a surge in the glutamate release. There is activation of the AMPA receptors. There is increased neurotrophic signaling. There is BDNF, that is the brain-derived neurotropic factor release, and mTOR, mammalian target of rapamycin activation, improved synaptogenesis, and rapid and sustained. This is the most important part, because in our clinical practice we find rapid effect, and the sustained effect that needs to be discussed very detailed, because rapid response is there with ketamine, but it has now been found to be sustained also. The pharmacokinetics: following intravenous administration, the ketamine concentration has an initial alpha phase lasting about 45 minutes with a half-life of 10 to 15 minutes. The first phase corresponds clinically to the anesthetic effects of the drugs. Following the IV administration, the ketamine concentration decreases due to combination and redistribution from CNS to slower equilibration within the peripheral tissues and hepatic biotransformation to norketamine. This is also very important, that ketamine can be administered only to patients who have normal liver function, without any liver disease or gastrointestinal diseases as such, because the active metabolite is norketamine, which ameliorates both pain, analgesia, and at the same time causes hepatic injury. Questions are coming, sir. Do I have to answer them right now or later?
Sir, after the presentation.
The redistribution half-life of ketamine from CNS to slower equilibrating peripheral tissues is about 2.5 hours. There is rapid distribution throughout the body, ability to cross the blood-brain barrier, which is very important. The ability to cross the blood-brain barrier has been one of the reasons why US FDA has given approval for intranasal S-ketamine. There is 12% plasma protein bounding. Predominant route of metabolism is the hepatic cytochrome P450. There is no other way. It is only by the hepatic enzymes, norketamine, and 4% is excreted via urine. So, coming to the routes, there are various routes and administration on dosage. Coming to the IV route, which is the most commonly used, actually by me or by other parallel colleagues who are doing research in various central institutes, the IV route is the most used and frequently, because of its bioavailability, is 100%. The dose ranges from 0.5 to 1, infused over 40 to 60 minutes slowly, twice. That we can come to later, the frequency. Intramuscular has 90 to 95%, not established. Subcutaneous, not established. Intranasal, 30 to 50%, significant differences between devices and the solution. S-ketamine 56, as I was talking, to 84 mg, intranasally twice weekly for 4 times. Coming to the oral part, which we will be talking about in details, the potential variability between capsules and liquid forms. In India, the capsules are not available, so they're highly variable. The bioavailability ranges about 10 to 25%, and the range of dosage comes to 100 to 250 milligrams 2 to 3 times per week, most accepted. Sublingually 20 to 30%, transdermal is 10 to 50%, yet to be established. So oral ketamine has bioavailability less than 10% due to extensive fast hepatic metabolism. Both S and R ketamine have half-lives approximately 15 minutes and elimination half-life of 155 minutes. Significant elevation of blood pressure would be a serious hazard if there is a known hypersensitivity to ketamine to any excipient. So hemodynamic instability, the adverse effects we worry about, the hemodynamic instability, the transient increases in blood pressure, heart rate and cardiac index. Emergence reactions vary in severity between pleasant dream-like states, vivid imagery, hallucinations, sometimes dangerous emergence delirium occurs. In some cases, these states have been accompanied by some confusion, excitement, irrational behavior. The risk of respiratory depression may occur with overdosage or too rapid rate of administration. Maintain adequate oxygenation and ventilation. However, something here is to mention is that ketamine is the only anesthetic agent which does not cause respiratory depression. It is basically a cardiostimulant. So risk of ketamine alone for procedures of the pharynx, larynx or bronchial tree, pharyngeal, laryngeal are not suppressed with ketamine when it is used alone. Avoid use as a sole anesthetic agent in surgery or diagnostic procedures of the pharynx, larynx or bronchial tree. Muscle relaxation may be required. In pediatric cases, I have not used, but there has long-term cognitive deficits that have been reported for if they have been used for more than 3 hours in children less than 3 years, and there is chance of drug-induced liver injury. So what are the proposed uses? The main theme of the topic today, treatment-resistant depression and suicide. So the Thas and Rouge classification of treatment-resistant depression, the staging levels, we have all come through this. Stage 1, failure of at least one adequate trial of one major class of antidepressant. Stage 2, stage 1 resistance plus failure of adequate trial of an antidepressant in a distinctly different class from that used in stage 1. The stage 3 is the stage 2 resistance plus failure of an adequate trial of TCA. Stage 4 is stage 3 plus resistance of failure of an adequate trial of a MAO inhibitor. Stage 5, stage 4 resistance plus failure of a course of bilateral ECT. So this was since 1997. But there is no standard definition for treatment resistance as of yet. The operational definition is that the major depression with poor or unsatisfactory response of too adequate optimal dose and duration. This is very important that I want to highlight in my presentation. That major depression with poor or unsatisfactory response of too adequate optimal dose and duration, trials of two different classes of antidepressant has been proposed as an operational definition of treatment-resistant depression. Treatment-resistant depression, I have taken this from Dr. Grover and Dr. Professor Awasthi's article. In India, the prevalence of depression is about 7.9 to 8.9 per 1,000 of the population. About 50% of the depressed patients do not respond sufficiently to a first course of an antidepressant therapy. About 30% do not show sufficient improvement and about 20% drop out due to tolerability issues. Half of the patients also fail to a second antidepressant treatment trial. Patients who do not respond to at least 2 antidepressant monotherapies are defined as treatment-resistant depression. So what are the factors associated with treatment-resistant depression? Several factors are there. Longer duration of the depressive episode, moderate to high suicide risk, anxious comorbidity, high number of hospitalizations, various age factors, dosage of antidepressant, and also comorbid substance use. Antidepressant, now what are the limitations of the current therapies we have? The antidepressant plus antipsychotic therapy. It takes a long time to effect as compared with intranasal esketamine. The non-pharmacological options for TRD is ECT, transcranial magnetic stimulation, which requires very much specialized staff and facilities. ECT, there is need for appropriate anesthetic expertise. Psychotherapy, if not previously tried, depression-focused psychotherapy may be added to an existing pharmacological treatment, but it is not considered a standalone therapy for TRD. Regarding VNS, it was FDA approved in 2005, however, the mechanism of action is poorly understood. According to the CANMAT, it is recommended to make adjustments if no improvements has been seen within 2 to 4 weeks of initiation of an antidepressant. In case of acute suicide risk, this time period may be unsafe and unsafely long, making faster acting agents appealing. And that is why today we are talking about ketamine. Suicidal ideation in patients with major depression. The Journal of Affective Discord reports that overall prevalence of suicidal ideation is 37.7%. Pooled prevalence of suicidal planning is about 15.1% in patients with major depression. So, management of suicidal ideation in major depression, ECT, transcranial magnetic stimulation, TMS. In pharmacotherapy, we can start from bottom down. We will start from lithium, psychostimulants, antipsychotics, hypnotics, anxiolytics, other antidepressants, tricyclic antidepressants, SNRIs, and SSRIs. So all these are options we have. Now, what are the clinical evidences in treatment-resistant depression? Intravenous racemic ketamine administered as monotherapy or adjunctively with pre-existing psychotropic regimens. Excuse me. Starting dose is that short term it has been studied in most of the studies. Dose range is from 0.1 to 1 mg per kg. Higher dosing from 0.5 to 1 mg per kg is superior in efficacy at the ground level when compared with lower dosing one day after administration. Upper dosing limit for IV racemic ketamine is not established. Evidence from single dose studies indicates efficacy at doses of 0.5 mg per kg as well as 1 mg per kg with no evidence of superior, that is 1 mg is not superior over 0.5. Some treatment emergent adverse effects with ketamine elevation in blood pressure are dose dependent. Higher doses of intravenous ketamine are associated with higher rates of treatment-related adverse effects, dissociation when compared with lower dosing. Clinicians administering ketamine should be aware of the greater propensity to adverse events and potential safety concerns when relatively higher doses of IV ketamine are administered. Short-term IV ketamine in TRD and frequency of administration. The ideal frequency of intravenous administration has not been established in adults with treatment-resistant depression. For example, results from multicenter double-blind study in adults with TRD indicated that acute antidepressants efficacy at day 15 did not differ between twice weekly and thrice weekly IV administration 0.5 mg per kg. Now, ketamine versus ECT for ketamine versus ECT for non-psychotic treatment-resistant depression. A prospective multicenter open-label randomized non-inferiority trial compared subanesthetic intravenous ketamine in ECT age with treatment-resistant major depression without psychosis. Intervention 403 patients were assigned to receive 3 weeks of treatments with either ketamine 0.5 mg per kilogram body weight or 40-minute period or ECT 3 times per week. Is the slide coming, sir?
What is that?
Slide is coming, sir?
Yes, the slide is there. Ketamine versus ECT versus for non-psychotic TRD.
Yes. Just sorry. It is not coming. It is not coming in my laptop. Open. Is it okay now, sir?
The slide is visible to me. Important points, IV ketamine.
Yes, important. Short-term randomized control studies have unequivocally established the rapid and significant efficacy of IV ketamine delivery in adults with TRD. Legitimate criticism to interpret the effect sizes reported with single or repeat dose ketamine in TRD. Possibly that non-specific effects such as functional unblinding, example by patients experiencing dissociation or euphoric responses and expectancy, may inadvertently inflate the efficacy of ketamine. So subcutaneous injection in depression, 12 articles were selected. There were 2 RCTs, 5 case reports, 5 retrospective studies. Given the small number of studies, found their heterogeneous nature, a meta-analysis was not considered appropriate. Subcutaneous ketamine was administered to unipolar and bipolar patients with single or multiple doses weekly or twice weekly with a dose titration approach, which was made in major studies. Dose ranged from 0.1 to 0.5 mg of racemic ketamine. Across all studies, subcutaneous ketamine showed a rapid and robust antidepressant effect. Now, subcutaneous racemic ketamine and esketamine in depression is a promising strategy showing beneficial efficacy and tolerability. Oral ketamine. Several uncontrolled studies reviewed by Showers and Rosenblatt and 3 small control studies have reported on the antidepressant properties of oral ketamine. They suggest that oral ketamine may also be effective in patients with treatment-resistant depression, and that side effects are overall more acceptable compared to the IV administration. Data from chronic pain management indicate that oral ketamine can often be safely used for longer periods of time, including at home. Means the patient can take them at home. Thus, oral ketamine may be a suitable alternative for IV ketamine in the treatment of treatment-resistant depression. Literature on oral ketamine is scarce, and the bioavailability of oral ketamine has been little studied. There remains a need to conduct larger controlled studies. Oral ketamine clinical evidences, systemic reviews. 22 studies, including 4 randomized controlled studies, 1 case series, 6 case reports, 5 open label trials, 6 retrospective chart reviews on patients ranging from 2000. All included studies reported significant improvement following ketamine administration. Ketamine was well tolerated without serious adverse effect. However, RCTs had high risk of a bias due to analysis methods and adverse events monitoring. Ketamine dosage varied from 0.5 to 2 mg as reported by the World Journal of Psychiatry. The frequency of administration was daily to monthly. Taken together, preliminary evidence suggests potential for antidepressant effect of oral ketamine. Intranasal ketamine, initial pilot study was conducted, showed antidepressant efficacy and tolerability of intranasal racemic ketamine given a single administration of 50 mg. Intranasal racemic ketamine has not been definitely established as a safe and effective in adults with TRD. Now, important points. Ketamine efficacy in TRD using oral, intramuscular, subcutaneous formulations has also been preliminarily reported. Of these formulations, the oral formulation has relatively more studies in TRD, with evidence suggesting efficacy after repeat dosing, with insufficient data though on efficacy within 24 hours. Oral ketamine has been compounded into capsules or mixed with juices to increase its palatability. Oral ketamine has extensive first-pass metabolism resulting in bioavailability of 10 to 20%. Similar to oral ketamine, the efficacy of subcutaneous and intramuscular ketamine in TRD has not been established with adequately powered, replicated, randomized, double-blind, placebo-controlled studies. In suicide, rapid reduction of suicidal ideation with ketamine has been reported. Suicide, we know, is a psychiatric emergency and medical emergency and needs to be addressed very urgently. However, the limitation is that lack of evidence demonstrating reduction in suicide completion and whether a more persistent reduction in suicidal ideation is observed beyond 6 weeks. Now, ketamine in suicide. The RCTs, 60 patients in the age group of 18 to 60 years diagnosed as major depressive episode, having modified scale for suicidal ideation, MSS scores greater than 20. Intervention, ketamine and normal saline. 3 infusions were given on week, that is day 0, day 2 and day 4, 3 doses. Now we can here find that after the first infusion, that there was this is the ketamine one, there is a decline in the score of the suicidal ideation, that is the modified suicidal scale ideation. There is substantial crossover, and it is coming down by day 4. It is maintaining up to day 6 compared to normal saline. Also here we can find this here. So change in the mean MSI score with time. and change in the mean HAM-D17 scores with time. There were significant reductions in the HAM-D17 score and MMSI score with 6 hours of the first dose in the ketamine group as compared to a normal saline group. Significant sustained improvement was seen on further days till first week in ketamine group as compared to the normal saline group. Conclusion is that ketamine might be a reasonable choice to fulfill the efficacy gap created by the delayed anti-suicidal onset of standard treatments. Now, systematic reviews and meta-analysis results showing the anti-suicidal ideation effects of ketamine, esketamine with both single and repeat dosing. The reduction in suicidal ideation has been reported to endure for up to 7 days from the previous administration. Repeat dose studies also indicate that reduction in suicidal ideation may persist up to 6 weeks in persons receiving repeated intravenous racemic infusion 0.5 mg per kg. Available evidence also suggests that the reduction in suicidal ideation observed with ketamine may be in part independent of its overall effect on the overall depressive symptoms. Here to highlight is that available evidence also suggests that reduction in suicidal ideation observed with ketamine may be in part independent of its effect on overall depressive symptoms, which we have talked earlier about the neurotransmitters, and we were talking about the mTOR, that is the mammalian target of rapamycin, which causes neuroplasticity. So this is the site where the anti-suicidal effect comes into effect, more than the reduction in HAM-D, that is the depressive scores. So, coming to the last few slides, the guideline recommendations for various ketamine formulations. Now, the clinical guidelines for clinicians. Weak recommendation against intravenous ketamine or esketamine. Do not use intravenous ketamine, esketamine in patients with difficult to treat depression, as benefits are uncertain and short-lived. The adverse effects are considerable and the long-term effects, including the risk of abuse, are unknown. The CANMAT recommendations for racemic ketamine in adults with major depression. Single IV racemic ketamine is the third line. It is a third line recommendation for adults with TRD. The need for repeated and maintenance ketamine infusion should be carefully assessed on a case-by-case basis with consideration of potential risks and benefits. Because of the limited evidence for efficacy and risk of misuse and diversion, the use of oral and other formulations of racemic ketamine should be limited to specialists with ketamine prescribing expertise and affiliations with tertiary or specialized centers. Now, how to use in inpatient departments. This part I am sharing with the permission of the chairpersons. This is how I use in my clinic, and this is how my senior residents are using in our case cities in the hospitals. So, if we are going to give intravenous, we are doing at 0.5 mg per kg body weight. The infusion is over 40 minutes using an infusion pump. The rapid antidepressant effect comes within 24 hours and it affects immediately. The closest one still now what we have come is that 230 minutes the antidepressant effects have come. Now IV ketamine was given on day 0, day 3, day 6, day 9, day 12 and last on day 14 respectively. Total 6 sessions of IV ketamine are given over 2 weeks. 24 hours after the last session, the scales are applied. During these 2 weeks, the patients are not being treated with other drugs till the last session of IV ketamine and application of scales is done. At the end of the last dose, ketamine, conventional treatment like antidepressants such as selective serotonin reuptake inhibitors are started. Now, how to use in OPD? If we are using the oral formulation, the fixed dose is 150 milligram. There are vials of 50 milligram which is available. So 3 vials, which is also very cost effective, have to be dissolved in 50 ml of fruit juice. There is need to be slow sipping over 10 to 15 minutes. A caregiver must be present. There are almost no contraindications for oral use. It can be given up to 3 times a week and can be given up to 30 to 50 sessions. Explanation is very important to the patient that it is only a temporary use and off-label use for both depression and suicide. It is effective for who are working people and students who cannot be admitted in hospitals for longer duration. So ketamine is a Schedule X drug. Intranasal esketamine has been approved, Spravato, Janssen, in March 2019. Clinical data are available for various formulations of ketamine in patients with TRD and suicide, either as monotherapy or adjuvant therapy. Need for larger RCTs to confirm the results. Schedule X drugs according to Drugs and Cosmetic Acts in India. Substances specified in the Schedule H and Schedule H1 or Schedule X shall not be sold by the retail except on and in accordance with the prescription of a registered medical practitioner, and in case of substances specified in Schedule X, the prescription shall be in duplicate, one copy of which shall be retained by the licensee for a period of 2 years. The supply of the drugs, Schedule H, H1 or Schedule X, to registered medical practitioners, hospitals, dispensaries, nursing homes shall only be made against signed order in writing, which shall be preserved by the licensee for a period of 2 years. Now, dispensing of the drugs. The persons dispensing a prescription containing drug specified in the Schedule H, H1 and Schedule X shall comply with the following requirements in addition to other requirements of these rules. Prescription must not be dispensed more than once unless the prescriber has stated thereon that it may be dispensed more than once. If the prescription contains a direction that it may be dispensed a stated number of times at a started intervals, it must not be dispensed otherwise than in accordance with the direction. So these are the important guidelines, and most important is that the substances in the Schedule X kept in the retail shop or premises in connection therewith have to be kept under queries are being put so much. So it should be kept under lock and key in cupboard or a drawer and reserved solely for the storage of these substances or in part of the premises separated from the remainder of the premises and to which only responsible persons have access. Supply of the Schedule X drugs required. The supply of the Schedule X shall be accorded at a time supply in a register bound and spirally page numbered, specially maintained for the purpose of separate pages shall be allotted for each drug. The following particulars have to be maintained in the register: the date of transaction, quantity received, name of the drug, quantity supplied, manufacturer's name, batch number, lot number, name and address of the patient purchaser, reference number, prescription against which supplies were made, bill number, date in respect of purchases and supplies made by him, signature of the person under whose supervision these drugs have been supplied. Accounts of the drugs in the Schedule X from the manufacturer, date of issue, name of these things have to be there. And that is all from my presentation today. Thank you.
Thank you, sir, for a very apt presentation. Over to chairpersons for their opening remarks. Then we can invite questions in the chat box, which will be taken to the speaker.
Right. Dr. Gua, a very lucid presentation covering all the aspects, covering all the forms of ketamine, OPD basis, IPD basis, how to give, what are the contraindications, the liver thing, each and everything. I must congratulate you on this wonderful talk. Over to Dr. Rajkumar, sir.
Thank you, sir.
I think we can take up the questions one by one. Right?
Yeah,
So,
that was, sorry, go ahead, Dr. Rajiv.
sir, please, you go ahead.
No, it was a wonderful presentation, certain perhaps a little eye-opening to me also as far as the oral ketamine is concerned, because the doses that we were using was much lesser than this, so we did not find much beneficial effect. Now, perhaps with this new dosage, let us try it and see if we can get up those same results. was definitely a wonderful lecture that eye-opening in certain areas to many of us, perhaps who have not been using ketamine, and should give us an opportunity to exercise certain confidence in using this as a treatment modality. Yeah, you can take up the question as if there is any.
Thank you, sir. Thank you, Rajkumar, sir. Thank you, Ravi, sir.
So this is a question in chat box by Dr. Paresh Shah. What are the side effects and precautions while administering ketamine? Effects on urinary bladder.
Once more, the question, can it be put up?
Uh, okay, we're in the middle of presentation. What are the side effects and precautions while administration of ketamine? Its effects on urinary bladder.
Yes. That is a very relevant question, sir. The basic problem with ketamine only is that it causes urothelial damage regarding the urinary bladder problems. There is a problem with the long term. If it is given long term for multiple times, then there is chances of urothelial damage and bladder carcinoma. But we are using sub-anesthetic doses. In sub-anesthetic doses, the basic side effects are dizziness, nausea, vomiting, hallucinations, imagery, headache, and sometimes acute exacerbation of psychotic symptoms.
Right. Dr. Gua, do you give something pre-hand to control these side effects like MSAT or other things?
Yes, sir. While administering the IV ketamine, we generally keep it in our modified ECT room that we have told you, and there is an ICU specialist. So the Boyle's apparatus is there. The pre-medication we use is that we give a injection of pantoprazole, we give an injection of domperidone, we keep in hand injection phenargan. Sorry, I am mentioning the brand name, but promethazine, and we keep in hand injection atropine and glycopyrrolate, and oxygen and ventilation is always there.
Right.
So, sir, what is your opinion about using ketamine in place of pentothal sodium in TRD while you are giving modified ECT, considering its prolonged seizure effect? Basically, in modified ECT,
Yes, sir.
pentothal, why not give ketamine?
So ketamine increases the seizure threshold level. Uh, However, in modified ACT, we have never tried means I've never given ketamine, so I won't be able to. I think probably I won't be able to answer this question if some seniors do guide me.
So another question on dosing of ketamine in acute suicidal episode. Bolus dose, please.
Bolus dose.
In
If it
acute,
is bolus dose, then it will be 0.75 to 1 mg per kg body weight dissolved in your about 0.1 is to 10 times dilution, and then given a bolus dose using a micro dip set at 60 drops per minute.
okay. Dr. Mehta, any comments on that?
But sir, regarding your previous question, if you don't mind, I would like to add that the bolus dose that can be given in ketamine for acute suicidal ideation, when a patient presents with severe suicidal ideation or has previously attempted, if there is a risk, then it is better to give the oral form. In the oral formulation, it is very easy. We just have to go for a ECG, a liver function test. Then we have to give 3 ampoules, break 3 ampoules of ketamine and mix it with apple juice to make it more palatable. Explain the patient about the dizziness and tell him to take it by sips over 10 to 15 minutes. The relief comes within 2 to 3 hours, and initially he should be explained that you will feel some giddiness for first 15 minutes, then you might have vivid dreams for the next 15 to 20 minutes like this. For the next 10 minutes you will be unstable, maybe you will be like an alcoholic, moving here there. But when you are free from this option and you can walk down a pace of 15 minutes, he can walk at a moderate pace for 15 minutes and can climb the stairs that we use as the normal recommendations, then you are fit to go home. So for acute suicidal, other than admitting the patient to IV for IV infusion, if oral is given, that is more effective.
But for that, patient needs to be cooperative. Sometimes acute suicidal patients are uncooperative. They are hell-bent on committing suicide.
That is a very tough situation, sir. Sometimes they do not cooperate, and then the admission, when the person is at risk to himself or herself, that is itself the MHCA guideline to admit the patient.
Yeah.
So
At
we
that
have
time, we need
to,
to give IV ketamine that time.
so at that time we have to admit him with the permission of his guardian or the
Right. There is
caregiver who is
another
there.
question in the chat box. What are the formalities needed by a psychiatrist to keep ketamine?
I have mentioned it in the presentation.
Right. There was question in the chat box.
Should I open that slide?
No, no problem, sir.
No, 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 okay, sir. Ketamine in bipolar depression and suicidal thoughts and risk of manic switch.
A very twisty question, sir. Actually, all the studies that have been shared by me today have been on unipolar depression. However, few studies have been done in bipolar depression. In my clinical experience, what my teachers have taught me and what other colleagues are practicing currently, a clear cut history where there is treatment resistant depression, that is drug resistant treatment, depression, along with CBT if there is no role, and there is no history of previous hypomanic episodes, then only it should be administered. However, the chance of euphoria, hypomania, acute agitation, I have myself faced 2 to 3 cases. In that cases, they had to be stopped the ketamine, and at that time, antipsychotics had to be given. So
So
there are chances.
was that switch into hypomania or mania regular, or did it stop with the ketamine effect?
It stopped within just after stopping ketamine, within 24 hours, it subsided.
So basically, that's a temporary
It's a
fix
psychomimetic
and
effect.
effect of ketamine rather than a switch into bipolarity.
Yes.
Can we say that?
Yes, of course, sir. That is not a switch into a
Right.
hypomanic
Right.
state. It is the acute agitation that sometimes do comes with the dopaminergic
So basically, that means
activation.
it is safe to give in bipolar disorder. Just we have to keep a watch over the agitation part.
Yes.
Right.
And any chances of increase in suicidal tendency with ketamine?
Very rare. There have been no reports. However, those patients generally who come or have a personality disorder underlying and are young adults, they do enjoy the effects of ketamine when they feel the ecstasy. They can take home the medicine, somehow they procure it, and there is chance that they do plunge into alcoholic habits, substance use disorder, then there is a problem. So then there is a chance of switching into a mode of suicidality. So basically, that trait has to be, because I mentioned in my presentation that the explanation should always be there that it is a temporary relief. It is not the permanent solution for the suicidal ideation. Still now, it has not been established.
Right.
So
There
we
has been
have to, once the patient is stabilized using the clinical scales or the clinical questionnaire or interviewing, we find that after giving oral dose of ketamine, if he is stable, and there is a mandatory acceptance, as also answering the previous questions, what a psychiatrist should maintain, the register along with a diary for the particular patient. That particular patient along with the patient party has to visit the clinic twice a week for first 1 month, twice a week for the first 1 month, then every month, then thrice monthly, at least continuing it for 6 months. Only then it can be stabilized. Once ketamine's action starts, the suicidal ideation is over after 2 to 3 sessions, then we can start SSRIs, or we can start fluoxetine olanzapine combination or lithium, whatever is appropriate according to the clinician's choice.
Right. Two psychiatrists have asked, is oral ketamine and IV ketamine is the same formulation or different formulation?
No, IV ketamine is in India it is the same formulation, because it is the IV ketamine only, the vials, we are breaking the vials and mixing it with the fruit juice. So in
Right.
India the availability is only the name of Themis is ketamine by Themis, and Arkemin by Neon. Actually what we do is that the anesthetist and the psychiatrist both propose to purchase, and they give their sign and stamp to the prescription, and the wholesaler or retailer, whoever keeps the schedule X drugs, he provides it directly to the institute, which is kept under lock and key. So only the injectable form is available in India, and that is given in the form of oral solution.
Right.
We don't have lozenges which are available in Australia. They have
Right.
ketamine lozenges.
Dr. R.K. Agarwal, an anesthetist, has asked he is using depression and for pain patient also. The patient who are having chronic pain with depressive symptoms, and they are also responding. So is ketamine helpful in the pain symptoms also?
Definitely, sir. There
Right.
has been chronic data that have been pooled, and it has been found ketamine ameliorates the pain symptoms.
Right. Any chance of dependence on ketamine? Another question.
Any?
Chances of developing dependence on ketamine?
Not yet reported, sir, but there have been chances. We have to be very cautious about the overuse, misuse. Dependence is late because procuring ketamine is not that easy, but the chances of misuse is there. And that is why many practitioners are not telling to give the medicine, take home medicine, which were previously being done by a national institute. I'm not naming that institute. From that institute, they were giving the take home medicine, ketamine, but it has been stopped right now.
Next question. Is it safe in pregnancy and lactation?
It is safe in pregnancy, but it is lactation, I have no data.
Right. Over to you, Dr. Aleem.
Any resistance to ketamine has been reported after repeated treatment?
Pardon, sir?
Any resistance to ketamine has been reported after repeated treatments?
Yes, sir. There have been few case reports. Even to ketamine, if the dose is not escalated, then there is a resistance. So it is not that the formula is not like that 0.5 mg has to be administered repeatedly, even after 14 days, 16 days, and concurrent use, because whenever we are using ketamine for TRD in IV form, we are stopping all the other psychotropic medications. Once the patient is stabilized from the acute TRD session, the HAM-D scores do reduce by 50%, response is noted. Then we start with the SSRIs and other augmenting agents. So at that time, if ketamine is necessary, then booster doses can be given, and then also sometimes we face resistance, and these things have been reported. But overall, the performance has been extremely well. Resistance to ketamine has come 1 or 2 case reports, but the results for improvement in TRD, when It is a headache for all the clinicians that what to do and what not to do. It is really a good molecule.
So why to stop SSRIs? Why not start SSRIs and continue with ketamine?
It can be done, sir. It can be done, but already a patient having failure to two SSRIs. So, if the patient is not kept drug naive, there may be chances of adverse reactions. But however, one article I have just come across, it was published in Indian Journal of Psychiatry, and that they have kept on fluoxetine, and it was no Indian Journal of International Journal of Methodology. It was from Jammu and Kashmir, and that they have kept on fluoxetine and intravenous ketamine. But that was only a single dose of intravenous ketamine they kept. It is better to keep the patient drug free for at least 3 to 4 weeks, 5 weeks for TRD treatment, because there has been already a failure and the patient is in-house patient. He or she is being monitored by the clinician every day, 2 hours, 3 hours every time.
So basically, so when to start the antidepressant at that time? After 5 weeks?
No,
Hmm. Or any group of antidepressant, when to start?
just 14 days, once 14 days after ketamine, three doses, 6 sessions have been completed with infusion ketamine. From the 14th day onwards, we can keep. I will just share this slide. That
Right.
will that will
And
just I think,
then both to continue simultaneously for some time
yes,
till
just
till the medication take their impacts.
yes, just a minute, sir. I will share this one. Is this slide visible, sir?
Not yet, not yet.
So we got that for 2 weeks not to give any medicines, and after 2 weeks, once the ketamine has its impact after 6 sessions, then we can start both
Hmm.
another group of antidepressant with along with ketamine.
Rajiv sir, why should we not
So this
start?
one is available, sir. Just have a look at this. At the end of the last dose of ketamine, conventional treatment like antidepressants such as SSRIs and started. During these 2 to 3 weeks, patients have not been treated with other drugs till the last session of IV ketamine.
No, is this some guideline or it is some protocol that you are following? Because why to
Yes,
lose 15 days for onset? Because antidepressants need some time to take onset of action. So the patients are severe patients, and once you stop ketamine, then you start. So there is a question related to it in the chat box. Anything specific about drug interactions with other antidepressants? Why should we why should we withhold antidepressants while on ketamine therapy?
So we are withholding antidepressants because antidepressants are not responding. We are treating a case of treatment resistant depression where already two antidepressants or three antidepressants, whoever be the clinician, that have failed for an adequate dose for an adequate period. A patient is given this period for a neat clean out or
so
washout period.
so
After
do
that
you,
washout, when we reinitiate ketamine, we see the response. We also study the efficacy at the same time. It is not only for studies, it is also for clinical purpose. Whether the patient is actually responding or not responding to ketamine. Within 24 hours, if the patient starts responding, that means that the next infusion, he or she will definitely respond. That response will improve. Then, at the same time, once the ketamine doses end, we start the patient with antidepressants, but keeping the patient still admitted for
so do
about 2 weeks.
so Dr. Goa, do you mean that in the 2 weeks when we give only ketamine, the ketamine will sensitize the brain to such a level that it will start responding to the other medicines?
So, neuroplasticity effects do start very early.
No, the antidepressants which were the patient was resistant to earlier, Uh, would he become sensitive to the antidepressant effect?
Definitely, sir, because synaptogenesis occurs, according to the literature I have shared, or I can share more literature. Synaptogenesis begins within 24 to 36 hours. Even as early as 230 minutes were reported.
So
So
why can't it
basically,
do it along with those drugs?
We can use, sir. We can use the fluoxetine that is commonly available, or sertraline. We can commonly use. What drugs the patient were previously not responding, we just have to take care that we are not using the same drugs again. We can just shift to another set of drugs.
So coming back to Dr. Alim's question again, whether it is only for the trial purpose, control purpose, study purpose, or is it a guideline not to use antidepressant for the first 2 weeks?
No, no, no. Antidepressants
What are the
used
antidepressant
for
the
the
person must on?
antidepressants not being used for the first 2 weeks is only for trial or study purposes. For clinical purposes, antidepressant can be given, and we are giving also antidepressants along with intravenous ketamine. Now, addressing again back to Dr. Alim's question regarding the drug-drug interactions, some interactions are there. We cannot omit that. But the overall response that if benzodiazepines are not given, then there is no problem. Benzodiazepines or SNRIs, if they are not given, that is better. It is better to give SSRIs.
and
Right.
does the treatment resistance breaks because of ketamine? Suppose patient was treatment resistant, and after ketamine he becomes treatment responsive.
So we have found the reports to be good. They are responding to the conventional treatments.
After a dose of round of ketamine.
After Even after a single infusion, they respond, and even after this repeated about 14 days, if we give the repeated infusions, they do respond. But the sustained effect, that is important, whether it remains sustained. Now, about say it is rapid, and the sustained effect remains for 2 months. So at that time, we need to reevaluate if further ketamine infusions are necessary.
Okay.
Because after 2 months, we need to keep a follow up on the patient also. But definitely with ketamine, whatever be the mechanism, whatever be the things that we have given or shared today, is from the series of publications and our own clinical experience. But whether the resistance breaks or not, or whether there are other psychosocial or biological factors or other comorbidities, because here we have to choose patients who do not have kidney disease, who do not have cardiac problems, who do not have hypertension, who do not have any major CNS disorders like seizure disorders, brain tumors. So, very selectively isolating patients. Often in clinical practice, we will face patients in TRD with a lot of medications that have been used. The patients are diabetic, they are hypertensive, they have some ischemic changes. So, at that cases, we cannot administer. So, even its role is very limited. The selection of patient is also very limited. We cannot give it as a mass, means it is not the full solution that we can come to. But instant solution for treatment resistant depression we can consider.
Any comment on ketamine assisted culturally attuned trauma therapy?
Ketamine assisted.
Trauma therapy.
Similar to thiopentol interview and other lorazepam interview.
Is that question in the chat box?
Benzodiazepine assisted interview.
Chat.
Yes.
Uh, the question
Which
is,
one?
any comment on ketamine assisted and culturally attuned trauma informed psychotherapy? That is the exact word of the question by Dr. Shekhar Yadav.
So I won't be able to answer this. Maybe the moderators, it is beyond my scope.
Okay, thank you. What percentage of TRD will respond to ketamine infusion therapy?
What percentage? That is a very interesting question. About 65 to 70, according to the literature.
And according to the experience?
More than that,
Okay,
90%.
right.
Because every time the sample size is being reduced, sir, because of the comorbidities we have to exclude.
Okay,
Every time. Every patient with major depressive disorder for a long time, say about 20 years, 25 years, they do have diabetes, they do have hypertension, they do have other comorbidities, renal comorbidities, multiple familial problems, stressors which need to be addressed. Psychosocial factors do play a role also in TRD. So every time the rate is very high because the sample size is always very low.
right. Any comparison of CBT with ketamine? Any studies on that?
I have not yet found.
Rate of infusion, I think you have told 0.5 milligram per kg body weight over 40 to 60 minutes.
Over 40 to 60 minutes.
Right. Active placebo with midazolam intramuscular post ketamine is good, sir. One of the contribution.
And a related question on this by Dr. Imran. Can IV midazolam 1 to 2 mg be given before IV ketamine to prevent confusion and hallucination?
Yes, that has been proposed by anesthetists who use it. Even oral midazolam has been also used.
We do practically
And
give. We do practically gives.
sometimes, if the anesthetist suggests that you give midazolam in these patients who are very agitated, who are very having acute suicidal ideation, or it is purely case to case basis, sir. Every case is a single subject is having a different profile. So that has to be decided. If that patient has a profile of committing or attempting a deliberate self harm, he has or she has a history of 2 to 3 times attempting, then giving midazolam prior to ketamine is better to avoid the acute psychomimetic effects and also to give some sedation.
Okay. Another question. What first line drugs would you like to give in case of adverse reactions like dizziness, dissociation, or sudden rise in BP?
Sudden rise in BP, generally, if the patient is receiving intravenous ketamine, then injection any and beta blocker is generally given, injectable beta blocker, and for drowsiness,
Make him
it
more
is
drowsy and
basically
sedate.
rest and drowsiness, and what else you mentioned?
Make him more
Dissociation
drowsy and sedate for the time being.
Hmm?
Give him more sedation to sedate him.
to actually sleep off.
Sleep off. Yes.
So we give the injection phenergan also if it is a he or she is acutely excited. That itself works. And antipsychotics as such, we can give olanzapine.
Right.
Any mortality reported during IV ketamine in
No,
India?
not yet. Not yet.
Can it be given to coronary artery disease patients who has underwent CABG in past but current cardiac status is stable?
No anesthetist will give permission for that. And no psychiatrist will take the risk. Very rare. It cannot be given, sir. Post CABG patient, it is purely a contraindication.
One
Post
of my
CABG means past
one of my
current.
patients is taking ketamine at home.
Pardon, sir?
Her brother is an anesthetist and she is taking at home. Taking ketamine infusion at home.
Could not get you, sir. Once more, please.
Never mind. We proceed further.
No, no. I could not get the.
I was just telling an experience. One of my patient, a young doctor whose brother is an anesthetist, is taking ketamine infusion at home.
Okay.
Yes.
So fine, if it has been monitored, then there is no problem. If it has
Regarding
been
the
monitored, there is no problem.
regarding the CABG, the question was the CABG has been done in the past, and now the patient is stable as per cardiac status. So in those patients, should we give? Should we not give?
We should not give so. Because ketamine itself is a cardiac stimulant. If there is any adverse effect with the limited, we some of us are working in national institutes or very much high tertiary institutes, but we do not get a cardiologist very often, and the risks, after explaining all the risks, no one will, even the family member will not give a consent for that. It is impossible to obtain the consent. We need a written consent from the patient and the caregiver or the guardian of the patient. So regarding ketamine and that we are giving it as an off-label use, we have faced some problems, not only in my studies, but even in clinical cases, other colleagues have also reported. Professor Kaustav Chakravarti, he is in the IPS, so even he reported that patients are refusing.
Okay. And can ketamine be brought by a duplicate prescription of a psychiatrist who is doing a standalone practice, or will it be given to institutes only?
No, it can be given to, like we have a setup. Considering myself, we have to obtain a pharmacy license, and we have a own nursing home setup. You can purchase from there, or you can directly refer the patient to a hospital, and giving the hospital prescription in triplicate, the hospital can purchase. A doctor can also purchase, but he has to keep all the things in mind, like maintaining the register, maintaining the date of date, batch number of the medicines procured, and whether they have been repeated prescriptions like that. So there are chances that it is being they just like nitrazepam or lorazepam giving, or methylphenidate. The At least in West Bengal, Kolkata, the pharmacists keep the copy of the Xerox copy of the prescription. So here also there are triplicate actually. One is to be kept by the patient, one is to be kept by the doctor, and one by the pharmacist. So no retailer will sell that. He has to purchase it from the wholesaler. The wholesaler will confirm it, and he will give directly supply to the doctor with the registration number, and then the doctor under supervision will administer it.
A person
Patients?
who is the person who is having standalone OPD, can
Hmm.
he or she buy it from the retailer, or will it be allowed, or will it not be
No,
allowed?
he can purchase. He can, if the retailer has the ketamine, then he can purchase. If the retailer does not have the stock, because no retailer commonly will, they will keep lorazepam injection, haloperidol injection, promethazine injection, but they will not keep ketamine injection until it is a nursing home where anesthetists are there or operations are going on. So standalone practice, it is very difficult. But if there is a contact with any distributor or wholesaler, then if the prescription has been given and he has been informed that you need to procure, maybe the patient can bring the vials, and then we can give it in OPD, means in OPD practice.
So theoretically, yes,
We,
practically different, difficult.
yes, the retailer has to be, actually the retailer cannot give, sir. They don't have that stock. That
So
stock
that
has to
means
be
you wish
bought
to
from
say
the wholesaler.
theoretically, theoretically, standalone practitioner can keep, but practically it is difficult. That is
No, no,
what
sir.
you mean.
No, no, sir. It is not difficult. Even in my clinic, in ours, means my clinic, Mononivesh, it's a setup. So there we keep the Schedule X drug. It is no
Right,
problem.
right,
It is no problem. But the entire registry diary has to be maintained.
right.
Okay, I think one or two quick questions. Arrhythmia is one of the rare complications. How do how does a psychiatrist deal with it? Arrhythmia, have you encountered it?
We have encountered tachyphylaxis, tachycardia. Arrhythmia, rarely we have found. We do a post ECG also, and even if the senior medical officer, senior resident who is there, if there is any chance, then the in medical colleges or in hospitals, so the cardiologist or the general medical practitioner is given a call for the arrhythmia. The psychiatrist has to refer the patient.
Okay, and there is a contribution from Dr. Rajiv for this, I think, raised BP. Maybe reduced dosage can be given with slow titration with suicidal ideation in case of CAD, okay, in case of coronary artery ischemia. And nifedipine sublingual is fast-acting antihypertensive provided there is no tachycardia. This is his comment, not a question.
Right.
Dr. Paresh says, I was given ketamine as anesthesia for in past for abscess drain. It was a very good and divine experience. So I feel the chance of abuse is very high. Anytime any of your patients demanded ketamine for euphoria from you.
Yes, the chances are there and they do demand it. So at that time, we have to be strict that we cannot provide you.
Okay.
If he is
Ideally,
taking in the oral basis, then we have to just tell him that we will continue your therapy, but it will be under supervision in hospital setup.
so last question, sir. We are already out of time. Injection ketamine comes in multi-dose vial. So can the same vial be used for repeated infusion?
No, sir. Repeated vial, once a vial is broken, no one will take the risk of using it multiple times.
Okay. So Rajiv, sir, any comments from you?
Nothing. Well done. Well concluded session.
I think Rajkumar sir has left. So Vishal bhai, if you're there, we can conclude the session with thanks to everyone.
Yeah. So, so thank you, everyone. Thank you, Dr. Thakurta sir, for giving a very elaborate description and presentation on ketamine. Thank you, Dr. G. Boss, for actually chairing it very well. And sorry, Dr. Rajkumar had to leave. So thank you, everyone. Thank you, everyone. I think we need more information on ketamine. We're still, I think, early phase. I've learned a lot, and I hope all of you also did. Over to Nalim, boss.
Thank you. Thank you, boss. Thank you, sir. Dr. Rajesh, Dr. Rajiv, Dr. Rajkumar, Dr. Tufan and Amrit in their absence, Vishal bhai for all the background work that you're doing, to the Torrent for supporting us, to the audience that is there, IPS Odisha State Branch, and everyone and who's there contributing and keeping the Thursday musings alive. So thank you, all of you, and if you can allow, we can close the meeting now.
Thank you, sir. Thank you, chairpersons. Thank you, the audience, for your patience listening. There have been some shortcomings in the presentations, but it is a matter of debate. It takes time because things are new, chances are new, availability is new. So we have to be more cautious. I hope that this molecule will be promising, and this platform I have come across. Thankful to everyone, all the moderators, all the chairpersons, and the entire IPS Odisha team. Looking forward to further contribution on this platform. Thank you.
Thank you, sir. Thank you, sir. Closing the meeting now.